Hello. Thanks for inviting me to present this Royal College of Physicians and British Pharmacological Society report on pharmacogenomics implementation, which was called Personalized Prescribing, about how we can use pharmacogenomics to bring scientific gains to the bedside and improve patient care. Could I possibly ask, I think I'm having a bit of trouble getting the slides. Oh, no. Okay. So pharmacogenomics, preaching to the choir very much here, using genetic information to improve our targeted approach to prescribing so that instead of an umbrella, one-size-fits-all approach, we can adjust and modify in the first instance rather than waiting for an adverse event or an inefficacy to then adjust that. So how the genes can interact with the drugs have many different mechanisms. Pharmacokinetics, so what the body does to the drug. So we absorb the drug, distribute, metabolize, and then excrete it. And then pharmacodynamics, so we get on-target effects, and at the right dose, hopefully that gives us efficacy. And we have on-target and off-target potential for adverse drug reactions, which are the problems. I want to draw your attention to this here, because we're going to talk more about metabolism. So cytochrome P450, hepatic, so liver enzyme metabolizers that break down medications to either activate them or inactivate them. And we talk about metabolizer genotype, and that means how those genes interact to be able to act on those drugs. And this is an example with Mendelian inheritance of how you can end up with extensive metabolizers with a liver enzyme, which means that they would break down the drug really quickly. Intermediate, which would be your normal metabolizers, and poor metabolizers, who would be those people that would get the medication but would have trouble breaking it down in the way that you might expect. So that takes us to the report from the RCP and the BPS. We did this report to look at the evidence for translating the great scientific gains in pharmacogenomics over the past 20 years into clinical practice so that patients can benefit from that. There's a unique opportunity within the UK setting because of the National Health System and the National Genomics Medicine Services. So we really want to translate that to clinical care improvement for all patients. The working party had representation from a wide array of medical specialties, as well as the general practitioners, pharmacists, a representative from the patient and carer network, and representation from national healthcare organizations. We heard evidence which was presented in deep dives from people nominated by their specialty groups and had working group discussions which culminated in the production of this report. In terms of the scale of the problem, so we all know that different people respond in a different way potentially to the same medication, and that unfortunately we can have a medication that doesn't work for someone in efficacy or a medication that has a bad side effect. I think what I really want to focus on here is the scale of that problem in terms of adverse drug reactions. So 6.5% of all acute admissions nationally are due to adverse drug reactions, and that's pretty big. And the fiscal cost associated with that is at least £530 million per annum. We now suspect that that's probably quite a conservative estimate, and it may well be very much in excess of that. So there's a growing number of prescriptions within the national healthcare system. At the last audit check in 2015, when you compare it to 2005, so just a 10-year gap, there was a 50% increase in prescription medications nationally. So that's enormous. People are living longer, but they're also living longer with a higher disease burden, with more medical conditions, and then they're being prescribed more medications, polypharmacy. And that's not an evenly distributed risk across different groups, right? So there's health inequality, and certain people are more likely to have more medical conditions and be prescribed more medications. So really, we want to work on the avoidable harm and what we might improve upon with pharmacogenomics, because these figures show that there's a lot of room for improvement. So to put pharmacogenomics in perspective, which I think is equally important, pharmacogenomics is one aspect of the responsible factors for inter-individual response variation in medications. Clinicians in the room, I think there's quite a few. Can I see hands up just to get an idea of how many clinicians? Okay, lots of clinicians, lots of scientists. Clinicians routinely factor in non-pharmacogenomic factors that can result in different response to medication. So things like kidney function test, how well can you excrete through your kidneys, liver function tests, weight, age, sex, these are all considered. But genomic variation actually is a realm that's not incorporated now in clinical practice. So lots of room for improvement there, but we need to keep it in perspective as well. It is just one factor. So then we arrive at the question of prevalence. If it's one factor, how important is it? So if we say how likely is any given person to have a pharmacogene, meaning a gene that if exposed to that medication would have an impact on prescribing, it's actually everyone has at least one pharmacogene. So then it's a question of exposure, right? How likely are you to be prescribed that medication? And Prof. Baker's group at St. George's did a longitudinal study within the UK system that showed actually that the answer is you're really, really likely by a certain age. So almost 90% of people over the age of 70 have been prescribed at least one drug which has a pharmacogene interaction and would alter prescribing. And actually a quarter of people have been prescribed at least 5. And that's only in the 20 years, in a 20-year span. So that's really quite significant, I think. So then we say that taking all that into account, personalized prescribing using genomic information has the promise to increase our efficacy from therapeutics, to decrease toxicity, and to help with compliance and give a more targeted approach to therapeutic initiation, dose choice, and therapeutic monitoring. So bottom line, we can do better, get a more efficient choice of medication and dosage, and by doing it, we could theoretically bypass this stage here, which is an adverse drug reaction, hospitalization, morbidity, and cost associated with trial and error, which could be avoided with a pharmacogene test. So, examples. Abacavir, gold standard example for current pharmacogenomics implementation, a medication used to treat human immune deficiency virus, and it used to be that between 5 and 7% of all people given abacavir had a hypersensitivity reaction, which is quite severe and can unfortunately result in death. There was evidence from a control trial in the early 2000s that actually, if you test first for a genetic risk allele, a HLA haplotype, and you do not give people that medication if they have that genetic risk for that reaction, you bring that risk to basically 0. Because of that, it's been many years now, not just in the UK, but internationally, that actually HLA testing prior to abacavir is absolutely mandatory, and it is done. The downside of that, not a downside, but people are less aware of it because it is very subspecialist. These are medications prescribed by specialty centers treating HIV, and general medicine is not really prescribing these medications. A different example, which is a bit more familiar to general medics everywhere, carbamazepine, used to treat seizures, some mood disorders, and also trigeminal neuralgia. And this medication, unfortunately, can be associated with Stevens-Johnson syndrome spectrum reactions, really nasty blistering rashes all over the body, which unfortunately in the worst manifestation, again, can be fatal. Good evidence that if you test for genetic risk allele prior to prescribing, you can really bring down that risk. But it's actually not routinely available within the NHS, and therefore it's not routinely done. The summary of product characteristics and therefore regulatory guidance is that particularly in people of Han Chinese Thai descent, so ethnic population at really high risk of that allele compared to others, this should be tested for prior to prescribing whenever possible. Fluoropyrimidines, chemotherapeutic agents used to treat different kinds of cancers, breast, GI, among others. We know that some people are at higher risk than others from their genetics, so from a deficiency in the enzyme that breaks it down, of having a bad toxicity reaction to this, which again in the worst case can be life-threatening, can be bone suppression, diarrhea, and there was evidence that if you check for deficiency of this enzyme, which is able to break it down in the first instance, you can decrease that risk. For that reason, NHS commissioned testing at the end of 2020, and now people are offered this test before being given fluoropyrimidines. So that's a good example. It is in practice now, but it's in the realm of oncology, which again becomes subspecialized prescribing. So I want to next draw your attention to aminoglycosides, which are a kind of antibiotic that are commonly prescribed really by all physicians. And there's an association of, unfortunately, hearing loss, which is a side effect that can be encountered after giving one of these antibiotics, like gentamicin, for example. And we know that there's a mitochondrial risk allele at RNR1 gene, and if people have that, about 1 in every 500, they can have a much higher risk of becoming deaf after getting an antibiotic. For that reason, the folks in Manchester have trialed a point-of-care testing in neonatal intensive care units, looking at this gene before prescribing gentamicin, really commonly given to newborns in the neonatal intensive care unit. And that test can be turned around in, I think, less than half an hour is their estimate at the moment. So that's a great example and more generalizable. They've done a point-of-care testing, which is something we'll discuss a bit later. But now I want to talk to you about two medications that hopefully will be much more familiar to everyone in the audience. So codeine, an opioid analgesia. It's a prodrug, so it needs to be broken down, we talked about metabolism, by CYP2D6 to get benefit from it, because you need to make the active metabolite, which is morphine. Unfortunately, about 8% of the UK are poor metabolizers, meaning 1 in every 12 or 13 people within the United Kingdom to be prescribed codeine, which any of us could be prescribed codeine tomorrow, everyone can have pain, are not going to get an analgesia benefit from that, so that's inefficacy. On the flip end of the spectrum, ultra-rapid metabolizers are going to be at higher risk of toxicity, more morphine than you'd expect at a standard dose of codeine, and that's about 1 to 2% of the population by comparison. Another example is Clopidogrel, very commonly prescribed across different specialties. It's another prodrug that needs to be metabolized by CYP2C19 to be an active metabolite. And the hope is that then that will inhibit platelets, and it's used in secondary prevention for this reason after someone's had an ischemic stroke or a heart attack, possibly with some stents. And that's really important because it means that the clotting won't happen again if it's working, and you can prevent a secondary occurrence. Unfortunately, in those that can't break it down to the active metabolite, they're not going to get that benefit, and there's lots of data that shows that actually they can then be at a higher risk of recurrence. So hopefully I've convinced you that we should be talking about implementing pharmacogenomics, but there's lots of questions about how we do this, and where in a clinical pathway, and to whom and when. And these are really important questions because the UK is in an amazing position to be the first to implement pharmacogenomics at scale, but no one's done this, so this is all very much in the realm of discussion. So NHS England has already undertaken work pre-COVID about eligibility criteria. We'd have to be really clear about who we're testing, what for, and what to do with that information. You can have lots of interesting discussions about cost efficacy. We talked about point-of-care testing in the context of just looking at gentamicin and RNR1. Fine, if you're looking for one gene to inform prescribing of one drug at point of care. But if you're talking about implementing at scale in primary, tertiary, and secondary care settings across the UK, really commonly prescribed drugs, that's not really going to be feasible. So you can talk about potentially panels, where you'd look once at a panel of pharmacogenes that can then be used to inform prescribing across the rest of an individual's life for multiple drugs, and that might be a good place to start. Now, cost efficacy, you're going to get a better bang for your buck the earlier you go in someone's life and the broader you go in testing. Obviously, there's downsides to doing that as well. The most extreme manifestation of that, and no one's suggesting this is a starting point, is those newborn screening happening with newborn whole genome sequencing. And for those newborns, they'll be sequenced at birth, and then theoretically, as they go through their life, you could pull out that pharmacogenomic information and use it to inform a lifetime of prescribing. For the moment, a panel approach seems like the best place to start, and point-of-care testing might be good in cases like the gentamicin or warfarin initiation. Diverse engagement is really, really important. We heard from other speakers today about how important that is in the setting of pharmacogenomics. So we need to make sure that we're getting representation that does reflect the diversity of the United Kingdom. Challenges outlined by the Working Party Group, clinical service design. So how do we implement this in terms of the existing structure of care? Consent. Yes, it is genetic testing, but no, it's not the same as looking for a BRCA gene. You're not predicting a disease or confirming a diagnosis. It's really more akin to testing kidney function tests or liver function tests. So you need to think about a little bit of a different framework. Pathways in terms of genotyping and laboratory considerations, and clinical standard assessments, clinical decision support. So you have to use this data in a way that can be interpretable. So one idea is, ideally in the future at some time, maybe patients would have on their phone an app, and the genetic information is there, and you can type in a drug, and it would give you a red, amber, green. Red, do not take. Green, yeah, go ahead, fine. Amber, proceed with caution, maybe start with a lower dose, or maybe do some more therapeutic monitoring. Funding, yeah, would need funding, definitely. This is a whole new service, and it's got to fit in somewhere in the funding scheme. Prescriber knowledge and education. So pharmacogenomics at the moment is a bit of a niche topic, and the colleagues in education for the report did some surveillance of what's available and found that actually the people we need to reach are post-registration clinicians who have the least opportunity to get this information, and part of that might be just-in-time resources, which people are in the process of starting to create so that we can support that need. Patient engagement and expectations of the utmost importance, public dialogue. We've seen that lots of people have been doing lots of great work in terms of public engagement, and that is going to be maybe the most important aspect of implementing a new service, along with clinical governance, making sure that it's fit for service and that it's responsive to sort of improvements along the way, and ongoing research so that we can continue to make the most of the opportunity. To this end, the working group came up with some recommendations, and they were that implementation would need to be across primary and secondary care. Most prescribing happens in primary care, so we can't just keep this in specialized services. Funding and commissioning really has to happen centrally, nationally, so that it's the same service being offered to everyone, everywhere in the UK. And that system for pharmacogenomics is going to need to really be very responsive and agile. It needs to take on board new information as it goes and be able to feed that back in iterative cycles. The need for comprehensive education and training programs. Health Education England has already done a lot here and is in the process of doing more. But clearly there's going to be a need for special support services for clinicians in addition to those just-in-time resources and further education resources. Ongoing evaluation of the service is going to be really important. That funding so that we can continue to make the most of the genetic information we're generating. And then again, that really important communication with the public and the media to get a real understanding from patients and the public of what they want from this and how we can deliver it. So thanks so much for listening to me present this report, and to everyone in the working group, and a special thanks to the Royal College graphics team who's responsible for the beautiful pictures I was able to share. Thanks.